So this is how these drugs are acting at various stages. Renin block, because of that no angiotensin, because of that no vasoconstriction, aldosterone effect. All this effect we have already seen, and thus it helps in prevention of hypertension, or it helps in the relieving of. Now effects on the respiratory tract, again let me make you clear that this effects again will be able to see only in the drugs which are depending on their selectivity. The non-selective one, which are having both beta 1 beta 2 activity, definitely they will cause bronchoconstricted, and therefore they should not be used, or we call it as a contraindicated. Contraindicated means in asthma it should not be used at all. So this is called as a contraindicated. Indications means used. Contraindicated means should not be used. So it means it should not be used in asthmatic patient. So again it will depend on the selectivity. Those which are having highly beta 1 selective, they may not have this kind of adverse effect, or it will be very shorter one. Okay, and if the drugs is having increasing order of beta 2 action also along with beta 2, then we will able to see in gradually manner this increase in the activity. Then effect on eye, that is it will cause decrease in the aqueous humor production, it will cause decrease in the intraocular pressure. We have seen it during our effect on the or ocular effect of the drugs. Okay, if you remember various cholinergic and anticholinergic drug and adrenergic, anti-adrenergic drug, we have seen it earlier how they are effective, and I told you if you remember that time that the details you will be studying it as ocular pharmacology, or drugs acting on ocular system when you will study in pharmacotherapeutics. So glaucoma etc., these diseases are there. So timolol is there. Timolol is therefore selected because it is specifically suiting more to the ocular one because of it has got systemic effect and pharmacokinetic impact it is having. Because of this pharmacokinetic and dynamic or toxicological impact, the timolol is only preferred as a ocular drug. Okay, it is much better than other drugs as a ocular, and timolol is therefore only beta blocker which is used in eye. So what are the metabolic effect? Because of it we have seen these are the reason how beta 2 receptor are participating into it, and there is a glycogenolysis is blocked. Therefore if the glycogenolysis is blocked, means conversion of glycogen, that is glycogen breaking will not be there to glucose. So it will cause hypoglycemia because glycogen is not converting into glucose, decrease in the glucagon secretion in pancreas, decrease in the lipolysis in the adipocytes, and it will cause sodium retention, that is second entry to decrease the blood pressure, that will be decreased, and thus decrease in the renal perfusion. These are the effects. So this effect particularly helps us in the hypertension because it causes decrease in the BP and decrease in the renal perfusion. So other effects are the metabolic effect. These are all adverse effects which are there with the beta blockers. So where this clinically used and how they are used? So they are used in various conditions. Beta blockers are used in many conditions. They are very important in hypertension. As I told you, this is one of the, if you go for pharmacotherapeutics, you will find that it is one of the primary drug which is used in hypertension. There are many drugs. So we call them as a first line drug, second line drug. When we call first line means most widely used or most widely preferred or recommended by physicians. So this is the first line drug in hypertension. They are very important in arrhythmias. They are important in angina pectoris. They are important particularly after myocardial infarction. They are important. So this is cover almost whole cardiovascular system. So in that cases, only thing example in CCF, which drug we will be using. Example, let me tell you now, and your knowledge should be, again as I told you, it should be application of knowledge, logical one. Example, can you use propranolol in CCF? No. Why you cannot use? There are important thing is it has got non-selectivity is one reason. Second important reason is it has got membrane stabilizing effect. So membrane stabilizing effect means what? Because of that this drug will cause decrease in the force of contraction and heart rate. So in CCF already there is a problem with the force of contraction, and therefore this can augment, this can add more into it, and it can be dangerous one. So we have to be very careful when we are selecting the drugs. Beta blockers can be used in CCF, but that they are with the caution. In myocardial infarction also, they are post myocardial infarction we are using, and we have to again select it in a very proper way. Then pheochromocytoma already we discussed earlier. Particularly it is what pheochromocytoma is a disease, that is, it is a tumor of adrenal medulla, that because of this adrenal medulla tumor, what it causes is, it causes more secretion of adrenaline, noradrenaline. Because of more adrenaline, noradrenaline secretion, what it causes is all this activity, just like fight and flight mechanism, they are there. So by the time the tumor is removed, we need to control, or we need to block the action, because the level of adrenaline, noradrenaline is too much. So all the effect, adrenergic effect will be seen. So we need to have a agent which is having alpha and beta blocking activity. The better drug in that case is of labetalol, carvedilol, etc., so that they will take care of all alpha beta activities. In glaucoma, white timolol is used, we have seen earlier. In hyperthyroidism, if you read the endocrine system, I told you after CVS we will go for endocrine. So if you read the endocrine system, you will realize the thing that whenever there is a hyperthyroidism, this causes more sensitization to sympathetic activity. Means because of the thyroid, increase in the thyroid activity, T3, T4 if it is there, or thyroxine or triiodothyronine, if these are more, then it causes increase in the sympathetic, that is sort of, we can say, receptor upregulation, or increase in the receptor sensitivity. So because of that, it will show more sympathetic activity. So to control this, along with thyroid drug, we have to give this drug which will be blocking the thyroid effects. In case of migraine headache, we are using as a prophylactic. We can use them as a anxiety. Again, if somebody asks you which beta blocker you will prefer in anxiety, and if I give you 4 options, so you have to be very sure, because we have seen it just 2 lectures before, or last lecture, that we have got 2 pharmacokinetic classes, lipid soluble, which are having lipophilic and hydrophilic. Those which are lipophilic can cross blood-brain barrier. Those which are crossing blood-brain barrier can only act on the brain. Now, if there is an anxiety, then, or if there is a migraine, then we have to basically use the agent beta blocker which can cross blood-brain barrier. Means they are lipophilic, metoprolol, etc. And the hydrophilic will not be useful, because it will not able to cross blood-brain barrier. So this is how it helps. This is simple common sense. If we club it together, then pharmacology becomes easy. If we if try to mug it up, then it becomes difficult. So all of a sudden it will come spontaneously when you make it in logical manner. Then how they are used in hypertension: propranolol, atenolol, bisoprolol, labetalol, they are used. Labetalol is particularly preferred in pregnancy, that is in hypertensive pregnant and hypertensive crisis, because it is blocking both alpha and beta, and therefore it has got dual effect, labetalol. And in pregnancy it is safer for the fetus and the mother both. So in that case, therefore, labetalol, there are 2 drugs only which are preferred in pregnancy, hypertension and pregnancy. These are labetalol, and another one is alpha methyl dopa. When we shall see alpha methyl, we have seen it in brief, we can see it in more detail also. So alpha methyl dopa is another drug which causes or which is there. Then cardiac arrhythmias, we can use bisoprolol and carvedilol, they are preferred. In angina pectoris, these drugs causes decrease in the heart rate, decrease in the cardiac work, decrease in the oxygen demand, and therefore decrease in the frequency of the angina episodes. So we can use beta blockers in that. Then for CCF we use beta blocker or agent like carvedilol. It has got because of one additional activity it has got, that is it is antioxidant and it is non-selective alpha beta blocker, so it is useful. And there is a oxidative stress is there many times in CCF, which causes the hypertrophy and all dilatation. So that this because of this carvedilol it can be reduced and it can be thus helpful. So this is used, but again it is not first line of treatment always in CCF. We shall see all other drugs which can be used. So this is how these beta blockers are useful. They are doing in myocardial infarction. They have cardioprotective effect. They decrease infarct size. They decrease the morbidity and mortality. They decrease the myocardial oxygen demand. They have antiarrhythmic action. Why antiarrhythmic? Because after myocardial infarction, many patients may die with the arrhythmias, and therefore they can decrease the incidences of sudden death. In glaucoma, already we have discussed how timolol is used. Then in hyperthyroidism, already I told you the reason why it is used. So it controls tachycardia, tremor, sweating, which are there because of the goiter or because of the toxic goiter rather, where hyperthyroidism is there. So in anxiety, we use propranolol. I told you only the drugs which are having lipid solubility can be used. So this is propranolol which can be used. Actually, we have got other many drugs in anxiety. So nowadays, propranolol is not that preferred, but yes, it can have anti-anxiety effect. When we shall see CNS, at that time we shall see it in more detail. Migraine, they are useful. They are used as a prophylactic. There are many drugs which are there in migraine, and they can reduce episodes of chronic migraine. They decrease the catecholamine induced vasodilation in the brain vasculature. Then they are example of this again is propranolol. Pheochromocytoma, it is used with the alpha blocker, or there should be drugs which are having both alpha beta blocking capacities. So here both type of drugs are there. They are to be given. Beta alpha blocker to lower the blood pressure, and beta blockers to protect the heart. So this kind of effect we need. So these are the effect in pictorial form. What are the adverse effects? Already we have seen bradycardia, hypotension, heart failure. It can cause. Then beta 2, because of that it can cause hypoglycemia, it can cause increase in the triglycerides, it can cause bronchoconstriction. Again, as I told you earlier, depending on the beta 2 selectivity, or if it is the cold extremities, electrile dysfunction and impotence. Then it causes intermittent claudications. That means these are vasoconstrictions are there in some of the persons, and therefore there are severe leg cramps are there in the persons. Then it causes depression, hallucination. Now again, which will cause depression and hallucination? Those which are able to cross blood-brain barrier. So those which are having lipid soluble, they will cause gastrointestinal disturbances, sodium retention, fatigue. All beta adrenergic blockers, they will mask hypoglycemic manifestation like tachycardia, sweating, and therefore it can be very dangerous, because if initial signs are there, hypoglycemic signs are there, tachycardia, sweating, then it becomes easy for diagnosis, or patient can understand something is happening. But if they are blocking it or they are masking it, because of the mask, it will not be realized to the patient. The patient will not feel tachycardia or sweating, and then hypoglycemia can go on increasing, and the person will receive very less glucose in brain, and because of that it can go into coma. That can be a very dangerous situation. So this masking can be adverse effect. So it is not causing anything, but it is just masking the important signal. If suppose some train is coming or some bus is coming and that signal is not given, so then just like accident can happen. Similarly, because they will mask this signal of tachycardia and sweating. So these are the signs to warn the person that see, you are getting tachycardia, you are getting sweating. That means you must have, you can check your blood sugar level. But if the person do not check it or do not do it, then it can be dangerous one. So this is how the problem is. Then precaution, again sudden stoppages should not be there. It will give withdrawal syndrome. It can cause rebound angina, rebound arrhythmia, or rebound myocardial infarction, or rebound hypertension. Why this happens? Because there is a upregulation of beta receptor. Now we have seen it earlier. If this receptor is blocked for longer time, then body think that somehow the receptors are not functioning. So many new receptors will be made. So fortunately, if you have got antagonist, you are blocking it, but the receptors are there. They are too much, and sometimes even secretion is also increasing. This noradrenaline, adrenaline. But as long as you are giving blockers, then this additional receptor or additional agonist will not able to act. But as soon as you remove it, then the sudden action can be there, and that is because of this reason. So this is drug has to be withdrawn gradually. How gradually? That means suppose earlier it was 40 mg per day, then slowly you reduce it to maybe 30 mg per day, then 20 mg per day, and accordingly you make it. Okay, so this is how known as a gradual withdrawing, and this is there in many kind of drug. You will find this in many drugs. This is important, and this has to be done for preventing the withdrawal effects of the drug. In what condition we do not give? We are contraindicating beta adrenergic. In heart block, they are not given. They are contraindicated. So beta blocker can precipitate heart block. In bronchial asthma, they should not be given. But cardioselective, already I told you, cardioselective you can give. Okay, only those which are having beta 2 activity should not be given. Peripheral vascular diseases, but cardioselective beta can again given. There is no problem. In diabetic patients, all beta blocker causing masking of the hypoglycemia. So if they are given, the caution has to be given. Her patient has to be warned. See if these kind of things are there, or you regularly keep eye on your blood sugar level. Then they can cause hypotension. Now, when we started hypertension, at that time also I told you that all these antihypertensive drugs, they can cause hypotension, and another one we call it as a postural hypotension. So this is also having this problem. It should not be given alone in pheochromocytoma, because otherwise more drug will be available for alpha receptor, and then alpha effect, very severe vasoconstriction it can cause. So when beta blocker is to be given, either it should be given having alpha beta activity like labetalol, that will be preferable, or otherwise the alpha and beta both blocker has to be given, because the drug which are the adrenaline which is released, which is acting on both receptor. So the first drug in that cause, that is, see, if you see here, is called as a prototype. Prototype means this was the first drug, and then what's your studies, what's your knowledge we have got about the actions, these are because of this drug. So once we study the prototype in details, then we have to make just comparison with prototype and other drugs, because basic things remain same, most of the things remain same. So it is a non-selective acting beta 1 beta 2. It has got membrane stabilizing acting effect to what we call it as a quinidine like or local anesthetic like effect. It has got sedative action, but it does not have any intrinsic sympathomimetic activity. It is lipophilic in nature, that's why we have seen it is used in migraine, or it is used in this anxiety diseases. Already we have seen it. So this is how, why? Because it is lipophilic. Because of lipophilic, we have seen when we compared it that lipophilics are completely absorbed. 70% are metabolized in first pass mechanism, 90 to 95% are protein bound. It can cross blood-brain barrier because it is lipophilic. It is excreted in urine, can be given orally or parenterally. Actions are membrane stabilizing, so it is having an antiarrhythmic effect, beta blocking effect. So antiarrhythmic effect, CNS has sedative action, it decreases the tremor, it decreases anxiety, and it is used to protect against social anxiety, performance anxiety, etc. But again, for anxiety we have got many safer drugs also, but yes, it can also be active in that case. Then cardiovascular system, that is beta 1 effect it is causing, so it inhibits the cardiac output or decrease the cardiac output, decrease the cardiac work, decrease in the oxygen consumption. it decreases the excitability, it decreases the automaticity and conductivity. There are dual effect because of the beta 1 effect also, and because of the membrane stabilizing activity also, and because of these two effect, these are effective or these are very useful. So it useful in the blood pressure because of the blocking beta 1. Here beta 2, that way uh, uh, they don't have much action in the beta, rather it can be adverse one. Then anti-hypertension action is because of the decrease in the cardiac output because of the beta 1 renin angiotensin, and presynaptic inhibition of noradrenaline, inhibiting the sympathetic outflow in CNS. So these are the major reason why they are causing. These are four important basic mechanism of action, which is which are common for all. Uh, so what are the actions? It causes vasoconstriction, so it decreases the blood flow, particularly to muscles and other organs except brain. Therefore it causes cold extremities. Bronchi, it causes bronchospasm, particularly in susceptible patient or already having bronchial asthma. It causes increase in the intestinal motility. Liver effect, decrease in the glycogenolysis, therefore hypoglycemia. In pancreas it causes decrease in the glucagon secretion. Then in adipocyte it causes lipolysis. In skeletal muscle it causes decrease in the glycolysis. So overall it, therefore it causes decrease in the blood glucose level and hypoglycemia. On peripheral CNS it causes local anesthetic like effect, it causes tremor, it causes anxiety. So what are the indications? Indications means where it can be used. It can be used in hypertension, arrhythmias, angina, myocardial infarction, migraine, pheochromocytoma, chronic glaucoma, tremors, anxiety and hyperthyroidism. Now I repeat, these are all because of beta 1, beta 2 and lipid solubility. As the drug will change, you have to make this note, as the drug will change, accordingly the effect or indications will change. The drug which are not crossing blood-brain barrier will not have any effect on anxiety or migraine, okay, because they are not able to reach to brain, okay. Then pheochromocytoma etc. Propranolol has to be always combined with the alpha blocker, but you can use labetalol. Glaucoma, we know that timolol is better one, so like that. But yes, it can be used because it has got actions. So it doesn't mean that nowadays it is used. This is where difference in therapeutics and pharmacology. Here we see that propranolol can be used for all these purposes, but when we go for therapeutics, we will see that propranolol is not at all prescribed for any of this. Why this is happening? Because there are much safer and better drug which are more having better things than propranolol are specifically used for hypertension. Instead of propranolol, we have got other beta blockers, other calcium channel blocker, other ARBs, other AC inhibitors. So there are many drugs which are available. They are safer and better, which are having lesser effect. Same is the case with the arrhythmia, same is the case with the angina, same is the case with the myocardial infarction. So we have got better drug, okay. So although propranolol shows this much good things or this much list of effects or usefulness, but nowadays in practice we do not use it in most of the condition. The reason is why we are not using, because better drugs are available. So in therapeutics you may not have any chance to have any details about propranolol, because propranolol is not used. But in pharmacology we prefer propranolol because it is a prototype, and whatsoever changes we are making, we are comparing with propranolol. If I have to compare with the drug like atenolol, then I'll compare. Then I'll say that yes, it can be used in hypertension, it can be used in arrhythmia, it can be used in angina, yes, can be used in myocardial, but it will not be. Atenolol will not be used in migraine because it is not lipid soluble, it is not crossing. Pheochromocytoma, it can be used, but again it is only beta 1. I'll prefer to have beta 2 or labetalol. It cannot be used in glaucoma because timolol is better. It cannot be better in tremors. It is not useful in anxiety and hyperthyroidism. It can be used, but again we'll prefer having both activity alpha beta, okay. So this is how we got difference. Now immediately we compared atenolol and propranolol on the indications. And why we compared? Because of the changes in the mechanism. Why changes? There are two basic changes, or three basic changes rather we had. What are these basic changes we had? That is just a minute.